Non-medical prescribing case study by Shen Ying Wang. A 50-year-old man presenting dysphagia and severe acid reflux, no weight loss. Patient was on 2 weeks referral for upper GI investigation. Past medical history, rheumatoid arthritis, drug allergies, penicillin. Patient has been on ibuprofen 1.2 grams daily for 2 years. A gastroscopy was performed. Only a grade C esophagitis with 3 small ulcers at saying Clot test negative. Biopsy later showed ulcerative esophagitis. Non-steroidal anti-inflammatory drugs and peptic ulcers. A peptic ulcer is a defect in the upper gastrointestinal mucosa that extends through the muscularis mucosa into the deeper layer of the gut wall. 2 major risk factors for peptic ulcers are: number 1, Helicobacter pylori infections, which in this case was excluded. Number 2, NSAIDs including ibuprofen can cause ulcers by interfering with the stomach ability to protect itself from gastric acids. Long-term use NSAIDs and severe acid reflux could be the causes of his condition. Diagnosis and prescribing decision. Based on NICE guidelines, 40 mg omeprazole orally once daily for 8 weeks, taken 30 to 60 minutes before meals. A repeat gastroscopy was requested to check heliums. Continue to take low-dose PPI as a prophylaxis. Patient confirmed no other drug allergies besides penicillin before prescription. Omeprazole is one of the proton pump inhibitor which has a pronounced and a long-lasting reduction of stomach acid production. The PPIs, introduced in 1989, targeted gastric HK-ATPs in treating peptic ulcers and gastroesophageal reflux disease. Pharmacokinetic and pharmacodynamics of PPIs. PPIs are inactive in their native form. They are initially absorbed via the small intestine and distributed to the gastric parietal cells, where they are activated in the acidic environment of the acidic vesicle and secretory canaliculi. Activated PPI binds covalently to the gastric HK-ATPs, while disulfide bound, and this leads to the inhibition of acid pump enzyme. PPIs are metabolized by liver and eliminated from blood. All PPIs have about 1 hour of the elimination half-life. PPIs are acid activity prodrugs. The presence of acid secretion is necessary for their actions. It is also important to keep PPI plasma level high until gastric acid secretes. Therefore, it is recommended they be given 30 to 60 minutes before meals to ensure the pumps are active. Non-medical prescribing is a new concept initiated by the government plans to modernize the NHS. It was well accepted by patients and many health professionals, based not just on immediate level of satisfaction from endoscopy practitioners, but perceived value to the endoscopy service as a whole. In this case, patient was diagnosed with grade C esophagitis and was given a prescription immediately, so patient can start his treatment at the same day as his procedure. This would limit any delays in his 6 and 8 weeks rescoped check-ins. Otherwise, patients would need to make an appointment with a GP or a clinic, which could potentially take weeks. WHO stated insufficient therapeutic effect could result in prolonged treatment, which can waste health resources and time, and consequently have a negative impact on the NHS. Within the endoscopy environment, an NP would enable a smoother patient journey and more consistently flexible patient-oriented care. The law, as it applies to non-medical prescribing roles, the Prescription by Nurse Act, was implemented following the recommendation of the first Crown report. This enabled endoscopy practitioners like me, on completion of a specific training, to prescribe in my daily practice. A second Crown report was commissioned in order to provide strategically and consistent direction for extending prescribing rights and responsibility to other group of health professionals. When prescribing medicines, the prescriber is judged against the standards of experienced prescriber carrying out their role. The Department of Health confirmed prescribers are responsible for every aspect of their decision-making. WHO defines rational use of medicine as giving the right medicine for the right patient at the right dose for the right duration at the right cost. It is important to remember law-related consent, confidentiality, and record-keeping also apply to non-medical prescribing roles. Ethical considerations. Prescribing is difficult. It requires thorough knowledge and understanding of the physiology of the disease and the pharmacological property of drugs. According to WHO, essential medicines are one of the most cost-effective ways of saving lives and improving health. Medication errors occurs in all health settings. Causes are numerous and include lack of knowledge, tiredness of staff, careless work attitude, poorly explained policies, unfamiliar dosage form. Medication error is probably the most preventable type of error in an endoscopic setting. Of all types of medication errors, prescribing errors is the most serious, as it can cause significant harm and death. Education about prescribing guidance have been proved significantly reduce total errors. By minimizing risk, consider the best interest of patients, and practice high standard, the risk of patient harm and the legal implication can be minimized. The principles are very useful to my future daily practice. Any prescribing errors occurs, it will be detected. I will make sure of learning from any mistakes. For example, PPI is associated with a small increase mortality due to cardiovascular disease, chronic kidney disease, and upper gastrointestinal cancer. As a qualified non-medical prescriber, I should therefore need to regularly check MHRA updates on drugs and their adverse effects. I should prescribe only medicines that I know to be safe, effective, and appropriate. Professional responsibility. Once I'm qualified, I have a duty of care to keep updated with medical regulations and ongoing safety profile, and I will liable for my actions, accountable for keeping my skills and knowledge to update, which are required in order to fulfill prescribing role. Appraisal, critical incident analysis, reflection, and objective data are available within my trust. They have been well used by my colleagues and will be used by me in order to support my future CPD. Competency framework are useful tool for self-assessment and identify CTB needs. In my current trust, an audit should. In the post-qualification settings, a high majority participants had been able to maintain a wide range of competency with their prescribing role. Accountability of a prescriber to their employers. My contract of employment outlined the instruction of my responsibility in my trust. I will follow these instructions with appropriate level of care and skills. If there is evidence of negligence, my employer has a right to exert disciplinary power. Once I'm qualified, my employment contract and job description should be reassessed and amended, adding whatever prescribing duties my employer wishes me to hold. Similarly, process needs to be in place to ensure I remain competency, and the employer has a duty to develop. Previously, NLPs reported they were much clearer about their own professional boundaries once they have completed a prescribing course. Continuing professional development. The aim of CDP is to keep up to date in my job with knowledge and broaden skill in order to improve healthcare delivery and meet service needs. Pharmacology and prescribing is rapidly changing. That requires nurse managers to ensure staff engaged in NLP receive regular CPDs. NLP is a new revelation to NHS. Therefore, those who are not medical qualified need a mentorship from experienced prescriber plus encouragement to be competent prescriber themselves. MMC established standard requirement of 35 hours of learning in the 3 years prior to renewal registration. For NLPs, delivery CPD requires support guidance from a senior pharmacist working in my trust to address areas such as pharmacology, prescribing, medication management, education. A portfolio is required to demonstrate a CPD record for non-medical prescribers. This portfolio will need to be reviewed, updated on a regular basis. CPD should be included multiple approaches, including workshop and study days to cover areas such as clinical skills training, legal issues, prescribing updates, interpreting statistics in order to update the pharmaceutical company data, the basic pharmaceutical updates, exploitation of local and informal non-medical prescriber networking, attending medical conferences, and e-learning. Updates are also useful resources. And the next 4 pages are the references of the presentation. Thank you.